rheumatology, pathology, lupus, or SLE. All right, so I want you to know that lupus is very, 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 very high yield. It's probably one of the most single important topics that we'll discuss in rheumatology, or honestly overall for pretty much every single disorder, every single organ system. The reason behind that is because it does affect multiple organ systems. And you know that the USMLE in step 1, they like to ask questions about things that have a plethora of problems that affect multiple organ systems and how it all comes together. So the way that I'm going to do this is I'm going to just talk about your normal presentation first. And then we're going to kind of dive into the details about SLE, all of which are important. There's nothing that's low yield here. If there is something low yield, I'll notify you, okay? But lupus in general, you should know everything about it because they can ask everything about it. So first off, what is it? It's an autoimmune disease, right? Very common for you to see that it's going to be in females, all right? So very common in females. And a classical presentation that you're going to see with this is going to be a facial rash that is known as like a malar rash. So it's like a butterfly pattern on the nose and cheeks. That's very high yield for you to know. They're also going to present with joint pain, and they could be febrile. Okay, so those are your key classical presentation. It's going to be a female of reproductive age with a facial rash, mainly a malar rash, with joint pain and could be febrile. All right? So that's the first thing I want you to know. Now let's kind of dive into a little bit more about what other symptoms you could see. The first symptom that I really care about is a hematological disorder, specifically cytopenias. So you can see pancytopenias on the CBC in patients that have lupus. Do not get confused and do not just rub it don't brush it off. If you see a patient that has thrombocytopenia, and they have somewhat of like presenting symptoms of lupus, that should be a trigger to you, okay? So look for those cytopenias. Look for pancytopenias. That's how it could also present, and they could hide it in the CBC without ever telling you a single thing about their CBC, right? They would just show it to you. Next would be renal disease. So we know that, as we talked about it in the kidney section, right? In our renal section, there's two types of glomerular dysfunction or glomerular diseases that can cause or that can be associated with lupus, that lupus can cause. The first one's going to be nephritic. So one of the nephritic syndromes that's associated with lupus is DPGN, right? So diffuse proliferative glomerular nephritis is very, very high yield for you to know about lupus. Next is going to be the nephrotic syndrome, which is membranous glomerular nephropathy, right? So membranous nephropathy, MN, is highly associated with lupus as well. So remember, we discussed that in detail in the actual in the renal section. So it's nothing too high yield right now for you to know, but remember, it is high yield when they test you on it in the renal section. So remember, nephrotic syndrome associated with lupus is going to be membranous nephropathy, and nephritic syndrome in lupus is going to be diffuse proliferative glomerulonephritis, or DPGN, right? And in association with the renal disorder is you're also going to see a deficiency of early complement protein. So this is just overall for lupus. Patients with lupus will have a deficiency in C1q, C4, and C2. So that's just something that is relatively lower yield, but I thought it would fit in with the renal complications of lupus. Next, what you're going to see is the antibodies. So what you want to know about the antibodies is, first off, what are they? You have anti-nuclear antibody positivity in lupus. You have anti-double-stranded DNA positivity in lupus, and you have anti-Smith positivity in lupus, and lastly, antiphospholipid positivity in lupus. So of each one of these, ANA, anti-nuclear antibody, is very high yield for you to know, along with anti-double-stranded DNA. What they also want you to know is for anti-Smith antibodies is that it's an antibody against SNRPs. Okay, and remember, from going back to neurology, SNRPs are essential in spliceosome formation. So anti-Smith is against SNRPs, which are essential in spliceosomes, which is something that they would want you to know as well. Okay, so those are kind of the antibodies associated with lupus. Now, there's one antibody that's associated specifically with drug-induced lupus, okay, and that's known as antihistone antibody. So if you see antihistone antibody positivity with presentations like lupus, you know that it's going to be drug-induced rather than an actual autoimmune disorder, okay? And the drugs that are mainly causing drug-induced lupus are isoniazid, hydralazine, and procainamide, okay? And what happens is that you have the drugs that are metabolized by N-acetylcysteine in the liver, and that's what causes the antihistone antibody, okay? Remember, if you see antihistone antibody, then it tells you it's drug-induced lupus, which is caused, the most common causes of those are isoniazid, hydralazine, and procainamide. And you have that antihistone antibody positivity due to the drugs being metabolized by N-acetylcysteine in the liver, okay? Or N-acetylation in the liver. All right, so that's your antibodies. The specific one is antihistone antibody for drug-induced lupus. All the other ones are going to be seen in all lupus, okay? Now, let's kind of discuss just like certain different topics that you're probably going to see in different sections. So let's start off with the cardiology section. So in cardiology, the question that you could see that's related to lupus will be Liebman-Sachs endocarditis. Okay, and Liebman-Sachs endocarditis, it's going to present with small vegetations on both sides of the mitral valve. Okay, and it's going to be sterile. Okay, so it's an endocarditis that's non-infective, so non-infective endocarditis, and it's usually secondary to lupus. Okay, so that's one thing that you can see. So small vegetations on both sides of the mitral valve that causes endocarditis, and it's usually going to be a sterile endocarditis, non-infective. Okay, we already discussed our renal section. So in the renal section, we have nephritic syndrome that causes diffuse proliferative glomerulonephritis, and nephrotic syndrome, which can cause membranous nephropathy from lupus, right? The most common causes are lupus. So you could see hematuria and proteinuria depending on if it's nephritic or nephrotic, okay? Now, common causes of death in lupus. Renal disease is the most common cause of death in lupus, all right? And that's very important to know. Lastly, what I want you to know about lupus is that patients that are anti-SSA or anti-Rho are, like, remember we talked about it in Sjogren's disease, but pregnant patients that have positivity for anti-SSA or anti-Rho have an increased risk for their newborns developing neonatal lupus. And so what I want you to know about neonatal lupus is that the patient's most likely going to present with congenital heart block, okay? They can have the periorbital or diffuse rash and cytopenias at birth, but the congenital heart block is the highest yield association with neonatal lupus. Okay, so that's kind of everything altogether for lupus. The last thing that I would want you to know is it's a type 3 hypersensitivity reaction, if I didn't say that prior, and we'll talk about those later on in the immunology section. Okay, so this is pretty much what your key takeaway points are for lupus, everything I discussed previously. Now, there's also something known as antiphospholipid syndrome, and they like to talk about it in conjunction with lupus, just because it's an autoimmune disorder usually secondary to lupus. It's most commonly seen in lupus. And it's diagnosed based off of like a clinical criteria that needs to be met. And so what you're going to see are a lot of thrombosis. Okay, so if you see arterial thrombosis and venous thrombosis, a huge history of that, that's one key takeaway for antiphospholipid syndrome. Okay, number 2 is recurrent abortions. So if I see arterial thrombosis along with venous thrombosis as well, but arterial thrombosis is much rarer, so it's weird to see. With recurrent abortions, my mind is automatically on the number one differential of antiphospholipid syndrome, okay? And so what you need to know are a couple things. First off, you need to know that they're associated with lab findings of lupus anticoagulant, anti-cardioleptin, and anti-beta-2 glycoprotein antibodies. So those are the 3 antibodies associated with antiphospholipid syndrome. So let's start off with anti-cardioleptin antibodies. Anti-cardioleptin antibodies can cause a false positive VDRL RPR, which is a false positive syphilis test. Okay, so patients with antiphospholipid syndrome have anti-cardioleptin antibodies, which is going to cause a false positive syphilis testing. Next is our lupus anticoagulant antibody. This can cause a falsely elevated PTT, prolonged PTT. Okay, so those are the 2 higher yield things in association with antiphospholipid syndrome. So lupus anticoagulant and anti-cardioleptin. All right. Now, finally, how do you treat these patients? Usually systemic, lifelong anticoagulation because they have such an increased risk for thrombosis. So that's all for our lupus and our antiphospholipid syndrome. If you have questions, please be sure to reach out.